is my pleasure to introduce our didactic speaker of the evening, Dr. Matilda Ong'ondi. Dr. Ong'ondi is a consultant physician and clinical hemato-oncologist at the Kenyatta National Teaching and Referral Hospital. She holds a Bachelor of Medicine and Bachelor of Surgery degree and a Master of Medicine degree in Internal Medicine, both from the University of Nairobi. She is registered with the Kenya Medical Practitioners and Dentists Council as an internal medicine specialist. She is passionate about clinical bedside teaching and mentorship. Dr. Matilda is a member of various societies, the Kenya Society of Hematologists and Oncologists, European Hematology Association, and International Society of Thrombosis and Hemostasis. Her presentation will take 30 minutes. So, ladies and gentlemen, help me in welcoming Dr. Matilda this evening. Welcome, Dr. Matilda.
Thank you very much. And I am glad to join you this evening, and also very thankful to the presenters for giving me this opportunity. I just want to confirm that you can hear me well.
Very well.
Okay, wonderful. So we shall start. So today I have a huge task of trying to cover a very big topic in just 30 minutes and trying to give you a broad overview. And hopefully what I intend to do is sensitize us. Maybe for some people it will be reminders on things that we look at when we talk about thromboembolism, which you know is a big topic. I was looking at the chart to see where people are from. I see not everyone has indicated or what they do, but a few people I've seen responded being from various facilities. So feel free to, if you have any questions as we go along, to note them. There'll be a question and answer session at the end. So we can proceed to the next slide, please. So to help us for our discussion today, we're going to look at various things. I'll spend a little bit more time on some, and for others, I will just gloss through. Seeing someone is saying network is bad, not hearing. Is this applicable to everyone, or are the other people able to hear me well? I don't know if it's just the one participant.
I hear you very well. You're
okay,
very clear.
Wonderful. So I'll spend a bit more time on some areas and then gloss through others because I have been informed that you'll be given the slides, and I've included some references as well to help us when we are going through the slides. Next slide, please. So when we talk about thromboembolism, or if we just touch on the subject thrombosis first, we can't talk about thrombosis without talking about this gentleman, Virchow, who was a German physician. He wore many hats, but is known as the father of pathology. And he came up with this description of risk factors in terms of big categories that would put a patient at, would make them more prone to developing a blood clot. So either stasis or vessel wall injury or hypercoagulability. And I just put this quote down there that shows you know, he even, when we talk about embolism, was talking about the detachment of larger or smaller fragments from the end of the softening thrombus, which are carried out along by the current of blood and driven into remote vessels. This gives rise to the very frequent process to which I have bestowed the name embolia. You can see even the English that he was using. So the reason we worry about thrombosis is why? One, because of the risk of pulmonary embolism, or for some patients, as we shall look at in the clinical presentation, that they present primarily with pulmonary thromboembolism. So those are the most common things that we shall see. So when we look at the individual factors, those factors, and I'm hoping if we can proceed to the next slide. If we bear in mind this virtuous triad, as we will bear in mind the virtuous triad and look at the various factors, various studies have been done, and they have found that some factors are more prone or have a higher risk of leading a patient to getting thrombosis than others. Now, all of them are important, and when we're evaluating a patient, we'll be trying to address and find out, does the patient have any of these risk factors? So I'll encourage us that this is one of the tables that we really need to go through and the article is found in the Circulation Journal. But if I was to just pick a few examples at random and then bring it home to what we commonly refer to as the virtuous triad. So if a patient has a fracture of the lower limb, we know that this patient will be immobile, depending on where the fracture is. So there'll be some element of stasis. Then also dependent on the site of the fracture, you may have some element of vessel wall injury. If a patient has a hip or knee replacement, again, you have the aspect that, yes, the patient may be immobile for a few days, but then you're really talking about vessel wall injury because of the surgical procedure. If I look at, let's go to the middle column, if I pick something like cancer. So a patient who has cancer, is one of the important risk factors that we look at, and we know that that predisposes the patient to having a hypercoagulable state. If a patient gets a stroke, they're immobile, so that contributes to the stasis. So having that big approach helps us, and then each time you're looking at a patient, you're trying to find out what is the risk factor. Is there something that's causing stasis? Sometimes that stasis may be because of a local obstruction. Maybe a patient has a pelvic mass. Is it because of vessel wall injury? Has the patient had trauma? Have they had surgery? Is it because of hypercoagulability? And in our context, also important to remember infections, especially something like HIV. So let's move on to the next. So when we look at the epidemiology, we know that is the third most common cause of morbidity and mortality after myocardial infarction and stroke. And this is when you singly look at cardiovascular diseases. I looked at some of the literature that's from my country, that is Kenya, just giving us a small glimpse in terms of what did the local data find. So there's a retrospective study that was done, small numbers, 128, and you can see the patient population was a young patient population. The mean age was 40.8, and look at some of the comorbidities that this patient had: hypertension, TB, HIV, some of them it was in the context of puerperium, so that's after delivery. Some were found to be diabetic, and others had a smoking history. But look at that mortality, very high, 28.1%. So that means this is a topic we cannot ignore. And then we have another study that was puerperium setting, and they found a 5-year incidence of 1.8 per 1,000 deliveries, most of these cases being deep vein thrombosis. And most of the times when people say deep vein thrombosis, they mean thrombosis in the lower extremities, and 5.1% only had pulmonary embolism. Another study was done in the context of cancer patients, looking at the incidence of thrombosis in cancer patients, and they found an incidence of 10.9%, being more in females, those who had comorbidities, and those who had a poor performance status. Next slide, please. So when we go on to clinical presentation, and this is also a very important part, because most of the time what you will be doing as a clinician or the first person who's seeing this patient, the patient may come with an obvious symptom, we'll go through them, or they may have vague symptoms, and what we need to have is a high index of suspicion. So if we move on to the next slide, and just starting from the very extreme left, which may be your right, is that we've said most of the presentations will be involving the lower limbs. So a patient may come with swelling, they may have pain. The swelling will be dependent on the level of involvement of the blood clot, such that maybe a patient who just has the distal blood vessels involved may just complain of calf pain and swelling, whereas a patient who has the proximal vessels involved may complain of their whole lower limb swelling or and having severe pain. Sometimes there may be change of color. Remember, there are other things that can cause leg swelling. So whenever I teach students, we talk about unilateral lower limb swelling and bilateral. So when you're thinking of DVT, this is a patient who has unilateral lower limb swelling, or if they have bilateral, one side seems more than the other, or they have pain. So this is very important. I've used the term proximal and distal, and most of the time this is in reference to the blood vessel that's involved, such that for patients who have involvement of the vessels distal to the popliteal vein, you call that distal. And when you have involvement of the more proximal vessels, so from the popliteal, femoral, iliacs, you call that a proximal DVT. And those ones are more prone to the term that we talked about at the beginning, the embolia, term, so pulmonary thromboembolism. Now, in the study, also in practice, you'll find this. Also, when you read the literature, you'll find that it's when you have involvement of the lower limbs, the left seems to be more prone than the right. And there's an anatomical reason for this. And this is because the right common iliac, as is illustrated in the picture in the middle, crosses over the left common iliac vein. So already anatomically, you have more prone, a more prone area, so that when you add your additional factors, then you find most patients will have DVT involving the left lower limb. Now, a patient, remember, each time we're treating or we find a patient with DVT, there's that risk of embolism. So the image on the right is a CT pulmonary angiogram, and you can see where the arrow is pointing. There's that grayish line across, and that is a thrombus, what is called a saddle thrombus. So patients who have pulmonary thromboembolism, how would they present? They may have shortness of breath. Sometimes all they may have is just a fast heart rate, palpitations. Sometimes they may have chest pain, depending on the extent of the clot. When you get the slides, look at that first statement that Vacho said. He said sometimes the fragments may be large, sometimes they may be small. It may be in the large vessels, in the small vessels. So also when patients have pulmonary thromboembolism, their symptoms will be dependent on the size of the clot and the vessel involved, because we know that when patients have a massive pulmonary thromboembolism, they can have hemodynamic instability. That means the blood pressures will be low. And sometimes you've heard of even patients who've died, and when a post-mortem is performed, they are found to have pulmonary embolism. So this is not something that's to be taken lightly. So to recap, you have the symptoms involving the lower extremities, the swelling, pain, maybe discoloration, and for the pulmonary thromboembolism, chest pain, shortness of breath, and palpitation. Sometimes they may have cough hemoptysis. Next slide, please. So those are the most common presentations, but sometimes you can have unusual sites. So most of the times when you listen to a talk on embolism, on thrombosis, you'll just either get focused on the lower extremities or pulmonary embolism. But we have to remember you can have other sites being involved. And what are those other sites? On the extreme, the portal, the splanchnic vessels. So you have the portal vein there, the superior mesenteric vein, inferior mesenteric vein, splenic vein. And if a patient has obstruction or occlusion of this from a thrombi, they may manifest as abdominal pain. Sometimes if this has happened over time, then you're having a backflow and what we call collaterals, and this can also be reported, in a good CT scan image that's done, or even just an ultrasound. Sometimes if you're suspecting this in a patient, when you ask for an ultrasound, then you need to indicate in your notes and say, please look or comment on the portal vessels. In the middle, there is the diagram showing the cerebral veins. So you can have involvement of the cerebral veins as well. So cerebral venous thrombosis, how would these patients present with headache? That's actually the most common presentation, headache. Sometimes in extremis, they may even present with a stroke because the occlusion may be in the major vessels. Like sometimes if the sagittal sinus is affected all the way, they can even have hemorrhage or an infarct. Or have altered level of consciousness. So all of it is dependent on what is the size of the clot, what is the rapidity with which it has developed. And the other thing is when you have these factors, most of the times you want to look for things that cause hypercoagulability. We've talked of infection, but later we'll talk about entities called thrombophilias, which are inherited conditions that can also predispose patients to getting thrombosis. And sometimes it could be because of blood conditions or blood malignancies, or like in the case I recall during training, one time we saw a child who had extensive cerebral venous sinus thrombosis. The child was in TeCLA, and the risk for this child was because of severe dehydration. Other contexts may be because of meningitis. So sometimes it may be local causes for the cerebral venous sinus thrombosis. And on the right, there is a diagram showing the veins in the upper extremities. So we say the lower extremities is more common, but this can also occur in the upper extremities. So here we are talking about a patient presenting with swelling of the hand, again, dependent on the vessel. If it's the neck vessels which are involved, they may have swelling of the neck. And in these instances, most times you find it's because of either the patient has had a central line, maybe if it's a patient who's in critical care, or sometimes we use lines called PICC lines, which are almost similar to your central lines for chemotherapy, for patients who are having procedures like pacemakers in situ, or sometimes it may be because of malignancies. There are times you find a patient having a mediastinal mass, and then that's causing compression of the vessels that drain the neck and the upper extremities. So these patients present with swelling of the neck or swelling of the face. So that's something to think about. So I think if we miss anything else from today's lecture, is to remember the risk factors and the clinical presentation, because the most important thing is to have that high index of suspicion, because if you don't suspect it, then that means you won't be able to go into the next step, which is what we are going to discuss now. That is about investigation. So if we can move on to the next slide. So when we look at investigations, I usually like talking about investigations in categories. There are those investigations that you will do to confirm your diagnosis. Then there are those investigations that you will do because they have an impact of the choice of treatment. And there are those investigations that you will do to look for the risk factors. We've talked about some of the risk factors. So in terms of confirming diagnosis, we've said again and again, high index of suspicion. So I'll start. I know the slides, the first thing is the D-dimer, but we, for this, I'll discuss it a bit here and then put it in context when we look at some scores. So what's the D-dimer? This is a blood test that measures the fibrin degradation product. So when the blood,
Dr. Matilda, you're muted.
Sorry, I was muted by the host. Okay, all right. So when the body dissolves the blood clot, the end product of fibrinolysis is a fibrin degradation product, and this is what the D-dimer is. And this is important because if it's elevated, then it infers that in the body there's some breakdown of clot that is going on. Now, there are other things that can cause the D-dimer to be elevated. So it's important to know it can be elevated in the context of malignancies, in a patient who's hospitalized, in cases of severe infection. We've seen that with COVID-19, it's one of the markers that is checked for, and in inflammatory disease as well as pregnancy. So when do we use the D-dimer then? It's very important for its negative predictive value. What does that mean? That if you do a D-dimer and it's negative, for sure that patient is highly unlikely to have a blood clot. The other important thing I'll just mention about the D-dimer is increasingly what's been advocated now is an age-adjusted D-dimer, because beyond the age of 50, the D-dimer increases. So what is encouraged now with most labs is to give references based on the age. Now, for confirming that clot, you'll need imaging. So for the lower extremities, your Doppler ultrasound, very important. And you want the ultrasonographer to tell you the extent of the clot. So a good ultrasound should tell, comment on the veins all the way from the distal to your proximal vessels, the iliac, so that they tell you where the clot is, but then also comment on how the other vessels are. And then for a pulmonary embolism, the best would be to do a CT pulmonary angio. There's some instances where you may not be able to do this, although increasingly now there's a protocol that has been approved for even for pregnancy that has a low exposure to contrast. But ideally, you'd want to really avoid doing that. But a VQ scan is what would be used, a ventilation perfusion scan, but we know this may not be available at many centers. So if we move on to the next slide. So we talked about tests to confirm. So your Doppler ultrasound of the extremities, lower extremities or upper extremities. If it's the abdomen, your ultrasound can help, but the best would be to do a CT as well as the neck vessels as well, especially once it's the deep veins. Sometimes beyond, the internal jugular, you may not be able to see so much more with the ultrasound. So most of the times the radiologist will recommend you do CT imaging, like if you think the patient has a superior vena cava thrombosis. So there are tests that you will do to try and determine the underlying cause. There are tests that you do to try and determine severity. Is this a patient who, like if it's in the context of pulmonary embolism, I'm going to manage at home or in the hospital? What are the treatments I'm going to give? So you want a blood count, UACs, LFTs, coagulation profile. That's a simple INR and APTT. So if you're just to get a few tests, at least a baseline total blood count so that you know what your platelet is, liver, and an INR if you may not have the liver function test, but that would be important so that if they are deranged, you know, you may want to alter the dose that you're giving. The INR and APTT are important because if a patient already has an underlying coagulopathy, that means the INR is abnormal and the APTT, depending on the level, you may not be able to fully anticoagulate that patient. So that's why you want to check these tests, because remember, we are to do no harm. So we do not want to cause bleeding, and sometimes the bleeding can be catastrophic in these patients. Next slide, please. So just because we don't have a lot of time, but I'll use some cases that I've seen. So this is just one case of a gentleman I saw a couple of weeks ago, 42-year-old, who presented with left lower limb swelling. So his entire left lower limb was swollen. And I mentioned that in the slide earlier, we talked about the D-dimer being used in those who have a low or intermediate score. So these are the scores. There's a Wells criteria for DVT, there's a Wells criteria for PE. And so for this gentleman, 42, he has no comorbidities, he's not had any weight loss, no change in bowel habits, he's not had any recent trauma, no recent surgery, and he has no wounds on his skin, no ulcers, and he just comes with this left lower limb swelling. Now, of note is that he works as a truck driver, so he's a long distance truck driver. So that is important in this patient, because if you recall our virtuous triad, he doesn't check off on any of the other things except immobilization that comes with long travels. So if we look at these Wells criteria, there's nothing to point towards active malignancy from history. His immobility for 3 days, surgery, no. Calf swelling, yes, one leg was swollen more than the other. Collaterals, no, the entire leg is swollen, yes. He didn't have tenderness when you examined him along the veins. He didn't have any edema. He walked to the clinic. Now, another important history. So anytime you see a patient, you want to ask them, is this the first time you're getting this problem? So like for this patient, this is the second time he's had this problem. A couple of months back, he was treated for the same. So this is a recurrent event, because he also came in with a Doppler ultrasound that confirmed the extent that this was a proximal DVT involving his femoral vessels. So you can see already he's scoring 3, so he's high risk. So if you're somewhere where you can't even do a D-dimer for this patient, you know, it doesn't, actually there's even no indication, because for him, his clinical and physical findings point towards DVT. So what would you do if you don't have a Doppler with you at that time? If there is no contraindication, you would start treatment as you await your Doppler, or as you refer the patient to the next facility where a Doppler ultrasound can be done. So if this moderate or low risk, they're the ones who you do your D-dimer, so that yes, if their score is 1 to 2 or even -2, because an alternative diagnosis, remember we said anything else, it could be cellulitis. So that's why you're asking, is there any trauma? Is there any wound? Is there any ulcer? It could be lymphedema. So that's why you would get a -2. So in those instances, then you do a D-dimer, so that if it's positive, then that tells you there's a higher likelihood that this is DVT. So you'd want to start the patient on treatment, or if you're able to get that immediately, do the Doppler and then put the patient on treatment. Next slide, please. Okay, so this is the Wells criteria for PE. So these are another case. This is a 67-year-old who I was asked to review. She'd been transferred from a town hours away, for those who are in Kenya, a place called Isiolo. And the lady is obese, but she has no comorbidities. So a month ago, she had fallen off from a motorbike and sustained a fracture of the left femur, for which an open reduction and internal fixation was done, and she was healing nicely, had been discharged, was ambulating with a walker, and then she developed shortness of breath. And so, of course, with that history, the thing you're worried about is, could she have thrown a clot? Could she have pulmonary embolism? And when she was transferred and landed in Nairobi, her blood pressure was fine. She did not have tachycardia, but her oxygen level was low. All right. So if we are to look at this score, did she have previous PE? No. Was she tachycardic? Her heart rate was just 100. She'd had surgery, so that gives her a score of 1.5. She didn't have any hemoptysis. From history, there was no history of weight loss, early satiety, no postmenopausal bleeding. She had normal bowel habits, no bone pain. So, you want to ask all those questions looking for malignancy. And on examination, she had swelling on the left lower limb. This was the limb where she had also been operated on. So could there be also DVT there? That's a possibility. So 3, and then alternative diagnosis less likely 3. So for her, you can see she's scoring 4.5. So there's the original version and the simplified version. Whichever way you look at it, she is already scoring on the PE likely. Next slide, please. So there's also another score that's used for PE that looks pretty much at the same thing, but so this is how we would then use these scores in a clinical setting. And where it's unlikely, then you do your D-dimer. Next slide, please. So I'll sort of go through the next part very quickly in the interest of time, because I have seen that already our time is far much spent. But I think if all that you pick is having that high index of suspicion and being able to do that initial workup, then I think I would have done my work well. Because that's where the ball is dropped on many occasions, or that's where many patients are missed because we are not thinking about it. So in terms of treatment, there are many drugs that can be used, and time won't allow me to discuss each of them in detail, but we have, I'll start with the far left, heparin. We have the good old unfractionated heparin that is used. However, we know for a long time and preferentially, it's given as an IV infusion, and this becomes a challenge. But somewhere around, I think 2004, the American chest physician guidelines actually advocated for the heparin to be given as subcutaneously, which helps then in a setting where you're not able to really monitor your APTT. This is unfractionated heparin. But if you have given a patient that, the volumes are usually very big. But it's important to know that, because in case you don't get low molecular weight heparin, you can still use your unfractionated heparin. The unfractionated heparin acts by increasing the effect of your natural anticoagulant, which is antithrombin, by blocking your factor 10, factor 9, factor 11, and factor 12. And then you have clexane. So clexane is much better because its pharmacokinetics is more predictable. It's given subcutaneously, and it's easy to use. And it's given as a twice daily dosing. Sometimes you can give it as a once daily. So it's 1 milligram per kg. And how does the clexane work, or the low molecular weight heparin? It works by blocking factor 10A. So if I go to the next one is the warfarin, or vitamin K antagonist. Good old warfarin, very good drug, very cheap, but has multiple drug interactions. So, and that's important to remember. If you're starting a patient on warfarin, you need to bridge. What does bridging mean? That means you can't start the patient on warfarin alone. You have to start them on an injectable anticoagulant, so that would be heparin, either your low molecular weight or the unfractionated, until they achieve a therapeutic INR, and we'll discuss about that in a few minutes. And why is this? Because initially, because warfarin will block your vitamin K dependent factors, that's your 2, 7, 9, and 10, but it will also block your natural anticoagulant protein CNS. So earlier on, it can actually increase the risk for your clot progressing because of blocking the natural anticoagulants. So it's very important to know, if it's the first time your patient is on treatment, you're starting them on warfarin, you need to bridge that until they achieve a therapeutic INR. And what does that mean? You want an INR that's between 2 and 3. Why 2 and 3? We'll see that in the coming slides. Now, the other, so a lot has happened, in the past years, and we have other agents. So the warfarin is very good, but you have to keep monitoring the INR. And if you've managed or come across patients who are on warfarin, they're doing the same thing. One day they come to the clinic, the INR is 2. Then the next time they come to the clinic, nothing has changed, the INR is 1.6. Or the next time they come and the INR is 3.7 or 4. Because of the many drug interactions. So we have other oral agents which are used, and these are more expensive. You have majority being factor 10A inhibitors, as I've pointed there, rivaroxaban, which goes by the brand name Xarelto. There's a generic in Kenya called Hates, apixaban, which is even more costly than the rivaroxaban. Then you have endoxaban and the betrixaban. So what I find in practice is the rivaroxaban has gained a lot of momentum, and it's being increasingly used, and especially now that there's also a generic that's available. Dabigatran is also another oral agent, but this one is a direct thrombin inhibitor. So the others are a factor 10A, and then the dabigatran is a thrombin inhibitor. So these are all grouped as your direct oral anticoagulants, or what is referred to sometimes as the new oral anticoagulants, although now they've been in the market for quite a bit of time. Next slide, please. So again, warfarin, and I'm mentioning this because it's what's commonly available. So, the range is between 2 and 3. Why? Because these studies were done, and you can see the red line is showing thromboembolism. If your INR is less than 2, you have a higher propensity of getting thromboembolism. That's on this graph that's on the left. Whereas if you look at the extreme right of the graph, that if a patient has an INR of more than 3, then their risk of thromboembolism is low, but then they have a higher risk of bleeding. So the effective is to keep it between 2 and 3. Next slide, please. So again, principles that we would look at is there any time you want to prescribe an anticoagulant? The next question should be, is there any reason why this patient should not be on an anticoagulant, or is there anything that would put them at a high risk of bleeding? So as I mentioned earlier, that's where your tests come in. What's the platelet count? What's the INR? How is your liver function test? What's the creatinine? Because like the new oral, the direct oral anticoagulants, there's most of them, except apixaban, you would not be able to use in a patient who has renal failure. All the others you would avoid. So you'd either be using your warfarin or put the patient on apixaban. Does the patient have hepatic disease from whatever reason, hepatitis, metastasis? Does the patient have low platelets? But also, if we are using heparin, we have to still think about platelets because of a condition called heparin-induced thrombocytopenia. And I don't have enough time to go into this, but whenever we start patients on heparin, sometimes they can develop an autoimmune phenomena where you get antibodies that are against the heparin, and those antibody drug complexes bind on the platelets, and they are cleared by your reticular endothelial system, causing thrombocytopenia. So you want to, if a patient is on your especially with the unfractionated heparin, you want to pay attention to that. What's the cost? You know, we've talked about these new drugs, good to give, not, you don't need to monitor, but what's the cost? Sometimes you may need to put the patient on the injectables, but each time, sometimes you have patients telling you, but this drug is too expensive. Ease of administrations. Very few patients like to inject themselves, yeah. And then what's the risk of bleeding in this patient? And that's an important thing to remember. Has this patient had a GI bleeding recently? Have they had, the other day someone was consulting me about a patient who needed anticoagulation, but they had just taken the patient had been conservatively managed for subdural hematoma, yeah? So when do you safely start anticoagulation in this patient? So we always have to think about, so at the beginning we talked about risk factors and then high index of suspicion, and now we are saying when you're looking at treatment, you want to do no harm. So you want to find out, is it safe to put my patient on this treatment? Are there things that I need to monitor? And I think now for the remaining part of it, I will just mention the slides because I'm seeing it's going to 5:45. If we move on to the next slide, and maybe someone can just let me know on the chat how much extra, how many few minutes I can have just to wind up. So when you see this patient the first time, you always want to ask, is this a patient I can manage at home or in hospital? And this would be dependent on a couple of things. So if it's DVT, it depends on what medication are you starting, or even if it's PE. Because remember, we said if the patient has is able to, doesn't have any complication or contraindication, you want to start them on the newer agents. On the limb, it's not a critical limb, meaning they don't have severe occlusion that's putting the perfusion of that limb at risk. Or you're not starting the patient on warfarin, meaning that you're not you don't need to bridge. You can start this patient on tablets, then they come to the clinic. And most of the times it will be a higher dose. So like, for example, rivaroxaban, when you start them on the treatment, you would give them a higher dose, that's 15 milligrams twice a day for 21 days. Then after that, they would go on 20 milligrams once a day. If it's a patient who has PE, depending on where you are, if we can move to the next slide, please. Next slide, please. So next slide. So that slide, the previous one was just showing a score that can help you to determine if a patient has PE. Do they need to be monitored at home, or started treatment at home or in the hospital? To be honest, in practice, depending on where you are, because if I wanted this table because if we go back to that case, the patient I presented who had a fracture, had surgery, and then she presented with shortness of breath. When this lady had an echo, we found that she had signs of right ventricular strain, meaning the clot was big enough that it was causing strain on the right side of her heart. Now, sometimes you may not be able to do that echo immediately. So if you look at these parameters, So she was hypoxic, she needed oxygen, so she needs to be in hospital either way. And then she had signs of right ventricular dysfunction. But sometimes you may be somewhere where, fine, you can check with their oxygen levels, you put them on oxygen, but you're not able to do those other additional things. So it's actually not unwise to say, I'll monitor this patient for 24, 48 hours, and then if they're stable, discharge them then on the tablets if it's a patient who's going to be on tablets. Next slide, please. So duration of treatment, most of the times, you'll be put the patient, if it's the first time, whether it's provoked or unprovoked, you're going to put them on at least 3 to 6 months of treatment. There are new guidelines which indicates that in the context where it is unprovoked, because most likely that means there's something else underlying, that they need extended treatment. That's beyond 6 months, but no one will give you a clear cut on for how long. Yes, please. Yes,
you
please.
have just 1 minute, please.
Not a problem. I'll actually stop here. Most of the times, what we look at is how, what are the risk factors that this patient has? Does the patient have a malignancy? If we can just finish with the next one. Sorry, I said I'll finish with this one. This is a table that helps to see what is the risk of recurrence in the patient. So for instance, if we go to the far end, a patient who has active cancer, they need treatment for a long time until the cancer is cured, or, and 3 to 6 months post the chemotherapy. A patient who's had recurrent DVT needs what we call extended treatment or long life treatment. A patient who has antiphospholipid syndrome. So it depends on what we had mentioned earlier. What was the risk factor? Is this the first time they're getting a clot? Is this a recurrent clot? So that's what would inform how long you treat this patient for. But remember, if it's a first episode, you're going to treat them for 3 to 6 months. And the new guideline saying if it's unprovoked, meaning that you've not found any risk factor, then you'd want to treat them for a longer time. So I think in the interest of time, I'm going to stop there. And what I will just emphasize on, you'll just look at these other slides, which look at the VTE in cancer. There's a slide that talks about what to do in the context of surgery, what to do in the context of pregnancy. We're not going to use those new agents. What about if the patient bleeds? Because sometimes a patient can bleed and they are on these agents. What should you do other than stopping the medication? Remember things like vitamin K for warfarin, your fresh frozen plasma, and then protamine where you have heparin. So let's go to the final slide, please. So in conclusion, I think even without touching, I told you this is a big, big topic. What I would encourage us is always to have a high index of suspicion. Remember about the risk factors. Always try to establish what is the risk factor in my patient. Then look at what are the tests that you need to do. There are those that you do for confirmation. And then choose the ideal agent for anticoagulation based on what we have discussed. Sorry, I didn't have time to go into the special considerations, but I hope that with what I've shared, that this would be able to help us. And then also when you get the slides, you can actually review the other subject matters in terms of what to do in the different, or what we call the special consideration. So thank you very much. And sorry, I have really gone over time. And I hope that this has been useful. And thanks to the organizers for giving me the opportunity.
Thank you very much, Dr. Matilda. That was indeed a marvelous presentation. I'm sure everyone has gotten something to take home with. Not to worry, participants, the slides will be shared with all of you. At this juncture, I'd like to recognize Dr. Imosemi, one of our hub experts, an obstetrician and gynecologist. Thank you for getting time to join with us. We'll now move on to the case presentation by Dr. Rita Nabwire from Kisumu Heart Center. And then we'll address the questions at the end of the case presentation. Just keep them coming. Dr. Rita, over to you.
Thank you so much, Angela. My name is Dr. Rita Nabwire from Kisumu Heart Center. I'm going to do the case presentation for today. So next slide, please. So we had a 71-year-old male who presented to us with a 1-week history of breathlessness, easy fatigability, orthopnea, shortness of breath on exertion, lower limb swelling, which is bilateral, chest pains and cough. There was no history of diabetes or hypertension for this patient, but he was on follow-up for BPE. Patient had been managed in a peripheral facility, the facility that referred to us for pneumonia. So evaluation of the chest X-ray at which was presented to us showed cardiomegaly, but there was no evidence of the lung consolidation. They had also done a rapid and PCR COVID test, which all turned negative. So our charge findings were as follows. The BP was at 139/92. Pulse rate was at 114 beats per minute. Oxygen saturation was 57% on 5 liters of oxygen, 5 liters per minute of oxygen, and then temperatures was at 38.6 degrees Celsius. So on clinical examination, the patient was sick looking. He was in severe respiratory distress, had mild pallor, peripheral cyanosis, bilateral pedal edema, and there was no jaundice. Heart sounds were heard, and there was also an S3 gallop. There was a left lower sternal border pansystolic murmur. There was respiratory, on respiratory exam, there was indrawing of the chest wall. There was scattered fibrils, which were had on auscultation. Next. So our diagnostic formulation was, we were thinking of COVID-19, atypical interstitial pneumonia, massive acute pulmonary thromboembolism with copulmonale, acute on chronic renal dysfunction, and acute decompensated heart failure. Next slide. Our management plan was to admit the patient and to carry out investigations. So for the full hemogram, HB was at 8.8 grams per DL with an NCV of 80.6, and the white cell count was normal. For the UECs, the electrolytes were normal. Estimated GFR was at 65 mL per minute per body surface area. We also repeated a COVID-19 test, which turned out negative. HbA1c was at 6.67%, and RBS was at 7 millimoles per liter. For the ECG, it showed sinus tachycardia. For the echo, the left ventricle was normal with an EF of 69, though there was reduced stroke volume. RVSP, which is right ventricular systolic pressures, were elevated at 65 with autopsy of around 12. PSA was elevated at 5.5. D-dimers were really high at more than 10,000 nanograms per ml. ProBNP was also elevated at 11,089 nanograms per ml. So our indicative diagnosis was pulmonary embolism with copulmonale. For the supportive care, we propped the patient up. IV normosaline was started, oxygen by non-rebreather mask. there was input-output monitoring. His chest physiotherapy was initiated, and there was also change of urinary catheter. The patient had suprapubic catheter. So we started the patient on rivaroxaban, 20 mg once daily. Palmofast, which is busentan, 62 mg, 62.5 mg once daily. Sildenafil, because of the elevated pulmonary pressures, 50 mg once daily. Prostaflo, which is a combination of tamsulosin and finasteride, 1 tab daily. Cipro-B, 10 ml twice daily, and IV ceftriaxone, 2 grams BD. So we continued monitoring the patient, and on the 4th day, we repeated our lab evaluation. For the full hemogram, HB was still at 8.8 with a granulocyte percentage of 84.6%. A repeat UEC showed still normal electrolytes. GFR had improved to 81 mL per minute per body surface area. For the pro-BNP, there was a reduction. Now we had 8,702.54 pg per ml, while the D-dimers had also significantly improved from above 10,000 to now 4,100 ng per ml. So the patient was still on oxygen therapy, but the oxygen saturations were improving, remembering that he came in with sats of around 51%. There was also decreasing orthopnea and decreasing respiratory distress. So we continued on the medical and supportive management. We discharged this patient on day 6 of admission, doing much better. That is the end of my presentation. Thank you.
Thank you, Dr. Rita. Many thanks indeed for the remarkable presentation. Before we go to the post quiz, we'd like to take a few questions. Dr. Matilda, I will throw these questions your way. And the first question is, how do you manage a pregnant woman who presents with DVT at 32 weeks? Dr. Matilda?
Sorry, I'm on mute. Thank you. All right. Okay. Thanks for the question. So in terms of managing, we didn't talk about pregnancy. So the important thing about pregnancy is at 32 weeks, remember, once you hit 3rd trimester, anything can happen in terms of premature labor and early delivery. So you do not want to use agents. So your options would be 2. We've said you can't use your DOACs in pregnancy or in breastfeeding. So you'd either be looking at using heparin. And in this context, you'd be talking about low molecular weight heparin. Now, at 32 weeks, because sometimes the challenge we face is you may have a mother telling you, I can't afford the Clexane. So again, there's also the balance. You may say, okay, fine, maybe we can push that you can use warfarin, because within you're going to be avoiding warfarin in the 1st trimester, especially the first few weeks because of the development, because it's teratogenic, and you're going to avoid it in the 3rd trimester because of its long half-life, and therefore, you know, the risk of postpartum hemorrhage if the mother delivers early or if you need to do a cesarean section. So sometimes you can stretch that to 36 weeks. So, but remember, you would need to bridge. You can't just start the mother on warfarin and then you need to have monitoring. So at 32 weeks, it's really that my preference would be to put the lady on Clexane. If this is not possible, then you can bridge and put her on warfarin. You know, the question would be, is this the first pregnancy? Is it, how were the other pregnancies? If she's if she's multiparous, if she's had other pregnancies before. So, so that would influence in her other pregnancies, were there issues of PPH, because then that would also help in that decision of saying, do I push her to 36 weeks? If she says cost is a big issue, if not, then I would do TeCLA. Thank you.
Thank you, Daktari. You just mentioned cesarean section, and there is a question here to that effect. What if there's a mother with a previous CS? Would you go for CS, having in mind the risks associated with surgery in DVT patients?
So remember that's a good question. So remember, the indication for CS is usually dependent on, we are guided by the obstetrician in terms of what is the indication. If this mother needs a CS, then the question is, how am I going to support her during that period? If, and just I'm trying to get that question so that I can address all the, let me just make this bigger, and that will be good. This will be helpful. So the indication for CS should not be, or not doing CS should not be the fear of the DVT. So what we do is, so the mother had a previous CS, would you go for a CS? So yes, she's a previous SCAR. What is the obstetrician's review? Is the obstetrician saying that we are going to do a trial of SCAR? If you're going to do trials of SCAR, remember, you still have to watch the clock, because if she doesn't deliver, you need to take her to theater. So all we do is support the mother. And in the context of a mother or a patient who needs surgery, what do? You use, if you're using TeCLA, if you're doing prophylaxis, you would stop it 12 hours prior. Usually if a mother goes into labor, you stop because they may deliver anytime. So if it's treatment, then you'd want to stop 24 hours earlier, because you're giving a higher dose than when you do prophylaxis. So I hope that's clear. So you'd not withhold a CS because your indication for a CS is guided by, making sure both the mother and the baby are safe.
Okay, we'll take a few more questions. Participants will try and answer all your questions. We have, I think, around 5 more minutes for questions and answers. There's a question from Nuosu. Kindly explain the relationship between thromboembolism and COVID-19.
Oh, yes. So time is what was not enough, because that was the last part of it. So what do we know about COVID-19? So one, remember when we looked at the triad, we talked about hypercoagulability. Infections, severe infections can cause hypercoagulability, can cause endothelial injury. What's been found, remember, COVID-19 has a spectrum, asymptomatic to your moderate to your symptomatic, who may have mild disease, moderate or severe disease. And what's been found in those who have a severe, moderate to severe disease, there's an overwhelming inflammatory response. So that in itself gives you a hypercoagulable state. But what was also found is that these patients have, especially in the pulmonary endothelium, because remember COVID, because of the receptors, the ACE receptors, the lungs are what is predominantly affected. And so what they found is that even at the local level, you have an endothelial injury. So there's what they call endothelitis. So it's for COVID, it's not just alone per se, your simple hypercoagulability, but then there's also that immune phenomena because of the overwhelming inflammatory response, and then the endothelial injury, as well as the changes that occur in the coagulation factors. So all that contributes to the higher risk of thrombosis. If I would add, I think at the beginning, even people were saying that now for those ones who have moderate to severe disease, we need to give them higher doses of prophylaxis if we don't think they have thromboembolism, but that was associated with a higher risk of bleeding. So the guidelines now stand at, you give them standard dose of prophylaxis unless a patient has a confirmed pulmonary embolism or a thrombosis, in which case you would treat them, and preferentially you would be using your low molecular weight heparin.
Okay, and the last question, how can we lower the risk of thromboembolism in cancer patients on chemotherapy?
All right, so that's a very good, loaded question. So these are guys who are targeting those special consideration slides that we didn't go through. So now when it comes to cancer patients, so remember in cancer patients, there are multiple things. One, there's a type, cancer in itself has been found to have a high risk of thrombosis. That's one, compared to the general population. And then some cancers have a higher risk of thrombosis. So things like pancreatic, brain cancers, which have a very high propensity. And then you also have the chemotherapy itself can cause a higher risk of thrombosis. So what we tend to do in cancer patients is that we look at the risk of cancer, of a cancer patient having a clot. If a patient has a high risk, then you're better off putting them on prophylaxis. There are some scores, like for multiple myeloma, which is one of the conditions where we have drugs that we use that can increase the risk of blood clots. Then there are things, if the patient is on those drugs, you would put them on prophylaxis. So in cancer patients, what we do is there are various parameters that we look at that tell us, is this a high risk for, is this a patient who's at high risk for getting a clot? Is the patient mostly immobile? If they are mostly immobile, they already fit the category, because immobilization, being in bed, most of their waking hour, the hours, then they are moving around, is a high risk. So if they are generally mobile, they need prophylaxis. If they are mobile, but they have maybe a past history of clot, they are on drugs that would put them at a higher risk, then you put them on prophylaxis. I hope that addresses the question.
It does, Dr. Matilda. Many, many thanks for the responses. We now move on to the poll quiz. Participants, you're encouraged to take the poll quiz. Let us test our knowledge gain, see how much we'll take home away from this presentation. The quiz has been launched. Kindly let's attempt the quiz. For those who joined us a bit late, you can take the poll quiz even if you didn't do the initial quiz. The quiz is open to all participants, even those who joined during the course of the presentation. There's a problem with question 9 participants. I've just posted the correct question. It's on the chat. Thank you. %, of us have done the poll quiz. The rest of us, let's finish up. We have a minutes. We are almost at 40%. Actually, we are past 40%. Well done, participants. The polls will close in 3 minutes. 50% of three more minutes. 51% have completed the poll quiz. Well done. Two more minutes. One more minute, participants, 1 more minute. Let's wind up. %, of us have answered. And we'll now end the poll quiz. Let's end the poll quiz now. Thank you. So we'll quickly go through the questions, and then we'll see how you were able to fare on. But remember, this is adult learning. Even if you didn't get a question correct, not to worry. You still go home with something. So Dr. Matilda, you'll help us with the answers.
All right. Okay.
Yes.
So are we going to put up the questions?
Okay, I can just read the questions and then
Yes.
you can give us the answers.
All right, no
So
problem.
question 1, which of the following factors contribute to thrombosis? There is stasis, there is hypercoagulation, vessel wall injury, and all the above.
Okay, I'm hoping everyone answered all the above.
Yes, 77% got that right. Yes.
Good.
Good. So the second question, varicose veins are a strong risk factor for thromboembolism. True, false?
Okay, so the pointer, the clincher there is strong. So remember this, after the initial slide, I showed you a table that showed some of the weak risk factors, and that's where varicose veins would fall. So that's why that is false. So if you just later go through the slides and look at the strong, the moderate, and the weak risk factors based on that table.
Okay, question 3. Thromboembolic diseases are the second most common cardiovascular diseases after stroke. True or false?
So that would be false, because if you recall the slide on epidemiology, we said amongst cardiovascular diseases, you have stroke and myocardial infarction. In fact, the other way, myocardial infarction, stroke. So it's the third most common.
Okay, question 4. A D-dimer test is one of the diagnostic tests for thromboembolism. True or false?
Yes, so it's one of the diagnostics. So not confirmatory by itself, but one of the diagnostic. Then your confirmatory would be your imaging modalities.
Very good. At least 97% got that correct.
Oh, great, great.
Yes, yes. The clinical presentation of deep vein thrombosis is characterized by this dizziness, fatigue, a feeling of warmth in the affected leg, then all the above.
So, okay, so for that question, I know it's a bit vague, but remember we said most times when people refer to the deep veins, most of the times it means the extremities. So that would be the choice that involves I think you said was it the feeling
of warmth in the affected leg?
Yes. Yeah.
Okay.
Yeah.
Okay, so that's the correct answer. 39% got that right. And then question 6. The PESI, Pulmonary Embolism Severity Index score, identifies mortality risk over a 60-day period. True or false?
Okay, so I won't fault them on that one because we passed through the slide quickly. So it looks at a 30-day mortality. So the answer would be false. And remember, we said that we are looking at those who have a high risk of having a poor outcome. Therefore, you want to manage them in hospital.
Okay, question 7. The following class of drugs is used in the treatment of thrombosis. We have calcium channel blockers, vitamin K antagonists, antihistamines, all the above.
I hope they got 100% on vitamin K antagonists. Okay.
74% got that correct, which is good. So question 8, antiphospholipid syndrome is a disorder of the immune system manifested by thrombosis.
So is that 8 or 9?
It's number 8.
Okay, all right, yes. Okay. So, for that one, I think the answer there should be all, because you raised the question so that there's a single choice. So we said age because it's something that tends to occur more in younger people.
Sorry,
then
Dr.
they
Matilda,
tend to have.
We are in question 8. Antiphospholipid syndrome is a disorder of the immune system manifested by thrombosis. True or false?
Okay. So yes. True.
Yeah,
true.
that one
Sorry,
is true.
I was going to number 9. Okay,
yes.
All right.
97% got that correct.
Good.
And then now
Very
number
good.
9, Yes. Number 9, which of the following is considered during the screening for thrombophilia? Age, recurrent miscarriage, recurrent venous thromboembolism, all the above.
Yes, so I hope they picked all the above. Yes, so again, we didn't go through that slide on screening, but so young age, recurrent venous thromboembolism, all that would be considered.
Yes, actually 55% got that correct.
Very good. Okay, good.
Thank you. Thank you, Dr. Matilda. Over to you, Ken.
Thank you so much, Dr. Matilda, Dr. Rita, and Angela. And really to everybody who's been on this call, those who've asked questions, those who've contributed in the chats. I will just remind ourselves that our next session will be on the 28th of October. That's in 2 weeks' time, in just under 2 weeks' time, 13 days' time, from 4:30 p.m. to 6 p.m. East African time. That would be, I think, 3:30 to 5 West African time. That should be correct. And these will be on the management of preeclampsia in a cost-constrained setting. The presenter will be Dr. Sarah Kranz. So welcome. We will send the link around because you're all on our emailing lists or WhatsApp lists, and we'll be able to send these out. You're very welcome. If you have any topics that you'd like us to cover in the future, please address us. You can put that in the chat before you leave, or you can use our social media handles to share with us any concerns or any suggestions for the future. Once again, our social media handles will be shared just before we log off. And on behalf of our partners, and in particular, the CDMS that's been hosting today, I would just like to thank everybody who has been part of today's organization and the participation. We are very indebted to Dr. Matilda Ong'ondi and Dr. Rita Ogwire for their very, very priceless contribution to today's success. Thank you so much.